Good. I'm looking at my clock. We have 20 minutes left until 5. I would propose that we take 3, 4, possibly 5 short questions or comments, and that I then take something like 5 minutes for a bit of a wrap-up and sharing with you some of the comments I have. So, may I invite you for reactions? Perhaps briefly say who you are and trying to be short in your point. Yes, please, the gentleman here, the gentleman over there on the second row. Pardon? I can't. The lady there, yes, third, and then in the back, the gentleman. You, sir. Yes, these 4. Let's start with these 4.
Yeah, I'm Shankar Prenja from PGI Chandigarh School of Public Health. My question is for the first and the second presenters, Tanya. Your study did show a rise in the hospitalization rates amongst the insured population, which you are associating with the RSBY enrollment. But my question is that there are a number of demand and supply side confounders which could have influenced the utilization of healthcare. So, was there an attempt at trying to adjust for this confounding effect of these demand and supply side confounders? And secondly,
okay, let's perhaps keep to one question. So this
just associated with that. And if we say that there is an association with RSBI, then is it a true increase in access, or is it something a manifestation of moral hazard or supply-induced demand?
Okay, technical question on confounding, possibility of moral hazard. That is noted. Let's go to the second. The lady there, please, madam.
I'm Ruhi Seth, and I'm part of the Cochrane Public Health Group and also with Oxford Policy Management. And one comment, well, both are really comments, I think. Mr. Sunil said that there were all these funds. The question about the utilization of funds, whether it's feasible, UHC is feasible, and said how there were lots of funds which were not used, and whether the system can actually use funds. So I think it's more about needing to increase the amount of money which goes down so that enough money can also go into building capacity to use those funds.
Mm-hmm.
So that was just
okay, interesting point. The panelists may react. I had 3 identified, yes, you, sir, and then the gentleman on the 4th or 5th row. Okay, I'll let you react first. Please.
I'm Krishna Rao from the Public Health Foundation of India. My question was to the 3 RSBY presenters. Well, I understand that RSBY plays an important role of allowing people to access hospital care from both the public and private sectors. But in your experience, has there been migration of, say, doctors and other health workers from public hospitals into private hospitals due to the growth of RSBY?
Okay, an interesting question on whether health workers have moved from one facility to the other. Let's take a 4th and final one before the panelists react. Please, sir.
I am Dr. Satish Raghavan. I am Deputy Director in Tamil Nadu Health System Project from Chennai. I would like to ask a question to Mrs. Malti Jaiswal, Consultant Health Insurance. The speaker, Tanya, had raised a question that roughly 100% of the thing, that is if a person spends 11,000 for hysterectomy, another 11,000 is spent apart from out of pocket like that. So I would like to know what are the redressal mechanism for that in your insurance as per your act, or what do you do in such cases?
Okay. Let me perhaps first give the opportunity to Mrs. Malti Jaiswal, because you have to leave in 5 minutes. So the last question was specifically addressed to you. Perhaps a short reply.
Yeah. I think it's working. See, there would always be a tendency in the hospital to fleece as much money as possible. That's beyond doubt, and the beneficiaries are not aware. The excuse earlier taken by hospitals because of delay in payment of claims, so they are, resorting to this kind of recovery of money from the insured no more holds good, because as per the Government of India directive now, every claim has to be paid within 30 days. You either deny it or pay it, it has to be settled, closed, and if you don't pay it, there has to be valid reason why you will not pay it. And there is a monthly reconciliation process is also on. Along with this, I think there are what currently is being done by the ministry and certain other NGOs is some random audits are happening. So where interviews of the beneficiaries or the hospital records, as per the MOU with the hospital, the insurance company can have a medical and account audit for the claims that have happened relating to RSBY. That's a part of a regular insurance contract. So this is starting to being in place. There are reports of food not being provided, transport allowance not being given. So it's not just the money having been charged to the patient for the surgeries. And I think it's to do with beneficiary awareness. Beneficiaries simply get scared by the doctor telling them, no, you have to pay, you shelve out. So it is their awareness as well which needs to be increased at the same time while the claims are settled for the hospitals on time. And I think 244 hospitals have been depaneled for malpractices. So if that is speeded up, that will send another message. Yeah.
Okay, thank you. Then I would like to come back to the question of the utilization or lack of utilization of funds. Your question, madam, whether capacity should not be, whether these funds could not be used to increase capacity at the operational level, at the district level. Who in the panel would like to, address this? Please.
Sunil.
Yes, please. You have the mic. Yes.
I think she is absolutely right on commenting that institutional capacities are built through systemic investments, which in turn actually increases the capacity to spend funds. So it's a virtuous cycle which needs to be created rather than the vicious cycle that health system was subjected to during the 90s. I think she is absolutely right on the point. I completely agree with her.
Any other member of the panel who would like to react to that? Dr. Sunil? Capacity building at the local level.
It is all fine about capacity and all those things. They are very nice words. But the bottom line I told you, why should a DHO spend more money than what he's not getting any incentive to spend? He's got a 1 crore of budget and then you give him 5 crores and then he says, why should I spend? Because more audit questions. And that's not only with NRHM funds, it's also with international funding. Believe me, when I was in WHO, I used to go, sir, let's do this workshop, let's do this thing. He said, Sunil, you also don't come, you don't want your funding, because more headaches you bring.
Okay.
And it happens with even research institutions. You look at any research institution, one PI handling 4 projects will stop handling 4 PI projects because he's not getting any extra money. So it's with us also.
So it's also about, not only about management capacity, but also trying gradually to get to a culture where management at the local level that is responsive to people's needs is something that is valued and recognized by the higher levels in the system. Okay, good. There was the interesting question by, all questions were interesting, but this one in particular by Mr. Krishna Rao, on whether there has been a shift from, by health workers from one facility to the other. Who in the panel would like to address this? Would you like to respond to that? Yes, please.
I think it's a double bonanza for public sector doctors because they are anyways getting incentive under RSBY in case they are providing services under RSBY. And secondly, like I said, we did not specifically deal with this question, but we had a huge number of hospitals which were empaneled actually belonging to the government doctors. So there's no question of migration, the bird has flown.
Any other reactions? Tanya?
I would agree with what she said. As far as what we saw, there wasn't really a migration of doctors or any professionals from government, public sectors to private sectors, but the existing practices in society of referring, like for instance, some ashas in the community are given some incentive to now in Gujarat, for instance, to refer 25 rupees to refer and to assist, to take patients to hospitals for hospitalizations also, just like they did for deliveries. And so now they get cuts, we have seen that they get cuts from private hospitals to take these patients to those hospitals for RSBY service deliveries. So the existing practices of referring patients from public to private, or of doctors encouraging patients to go to their own private hospitals, those have been exaggerated. But we did not see migration of staff as such.
Okay, then there is the final question, which was the initial one that was raised, a more technical one on the possibility of confounding in the analysis. Who would like to address this? Tanya?
We did see an increase, a significant increase in use of hospitalizations, but this was between enrolled and insured patients who had used the card, when we compared it with enrolled and insured patients who did not use the card. So in the same group, we found a difference between those who used and those who did not use. We did not look at the numbers we had in the other groups were unfortunately too small, so we did not try and make comparisons between the non-enrolled RSBY and the enrolled RSBY. How to interpret increase in hospitalizations is something that even is difficult to say. Because for instance, so when we went around interviewing stakeholders, some people would look at it as saying, "Dekho, increase in hospitalizations, this means improved access." Some people would say, increase in hospitalizations, and you see high surgical treatments, this means doctors are giving, are doing more surgeries. Some people would see doing more surgeries or higher surgical rates as moral hazard. But then there was also a relative decrease in the medical packages, like what even Madam Nandi mentioned. There's a decrease in medical packages. So there's this apparent increase in surgical hospitalizations. So it's very difficult to really say what this means. But there are various factors, and it is definitely of great concern. That much I will say.
Thank you,
We
Tanya.
were definitely
Final
seeing
reaction?
in the public hospitals irrationally getting people hospitalized for very simple, malaria, diarrhea, which did not require hospitalization, because the hospital wanted to, was saying, okay, we don't have these drugs, or we want to increase our utilization, so you are here. So that is a rampant practice now in all public hospitals, that conditions requiring no hospitalization are admitted, very simple medical conditions. For 3 days, 5 days, very simple tests are done, and drugs provided. So that would be one reason for increase in hospitalization.
Okay, thank you very much. If you would allow me to share with you a number of comments that came to my mind when looking through the abstracts initially, but also listening to the presentations. Let me first say a couple of words on RSBY. I think we should not forget that the age of RSBY is only 4 years, so it's very young. We should, of course, give time to time, and if we look at some of the other Asian countries who have succeeded in achieving universal health coverage, I'm thinking of Korea, but in Thailand this has taken years, 10 years, 15 years. In my country, in Belgium, it has taken a century. So there are lots of problems, but we should acknowledge that it has only started. From the different presentations of RSBY, where the situation on the ground was analyzed, it appeared clearly that people are lost, if I may say so, at the various steps of the program being implemented. People that are in principle entitled to benefit from the RSBY at different stages of the implementation process are dropping out. Now, that is of course a very problematic situation. The point I want to make is it's not only important, it's not only relevant to know how many people drop out, but also to know who are these people, what are their characteristics, and what are the reasons why are they dropping out. Who are these people? To some extent, Tanya has provided an answer when she said that women within the household and under fives within the household are, for a number of reasons, are being excluded from the entitlement they have to use and to pick up the benefits of RSBY. So there's a form here of intra-household exclusion, which is very interesting, which can be very relevant in a later stage to adapt the design and to make it more friendly, more targeted vis-à-vis these intra-household exclusion. But there are probably other mechanisms not within the household, but within the community and within the district and within the society at large. So I think it is very relevant to identify who these people are and what the processes are that exclude them actually. It's probably a mix of social, political, economical, and cultural processes that lead to people being excluded. If these can be properly identified, but I formulate the hypothesis that it's not lack of technology that is the main that is going to be the main obstacle. The main obstacle is going to be much more likely be of a social nature. So technology is fine, but let's not overestimate its impact. It's not going to overrule process of exclusion that are often deeply rooted in society and in culture. That's the first point I wanted to make. A second point I wanted to make is and it has been mentioned this morning as well, is the need to properly monitor, to properly evaluate, to properly regulate the supply side of care. Are the services that are supposed to be there, are they available in the first place? Are the services to which people are entitled, are they being offered by the provider? We have heard experiences where this is not the case, where some of the services that should be there are not offered. And of course, the quality of care needs to be monitored. So a huge area of work is precisely to invest in this regular, continuous monitoring and evaluation system and try to develop a performance regulatory framework. Universal health coverage the option cannot be to promote people's access, to facilitate people's access to poor quality care, even to irrational care, let be to dangerous care. So the need of monitoring, evaluation, and regulation is extremely important. A third point I wanted to make is on the use or the limited use or the poor use or the inappropriate use of some of the public funds, some of the untied funds that are being allocated to the district level. And there I think an issue is to indeed to develop capacity at the local level, at the district level, so that people, the district managers or the taluk managers feel enabled to use these funds in a way that is responding to the needs of the population they're supposed to care for. So it's definitely also about a culture where these, let's say an organizational culture where management and initiative taking at the local level is being developed. Management at the local level, at district level or taluk level is not only executing what is coming from the top, it's not only implementing programs in a top-down way, it's also planning from bottom up, trying to take the pulse of what is living in the community and trying to provide an adequate response to that. And there, I mean, the existence of untied funds is a marvelous opportunity to give a concrete expression through creativity, but also this implies, of course, that the local managers are aware, listen to the people, and identify and collect what the priorities are for the people, and trying with these untied funds to develop it. Hence the importance, I believe, to invest also in management capacity at the district level. And I know that the Public Health Foundation of India is investing in that, and I know that IPH has very concrete plans in a couple of months to start with an MPH precisely trying to develop this management capacity. A fourth and final point I wanted to make, I wanted to come back to something that Dr. Sunil said, which is quite interesting. He criticized a little bit, and rightly so, I think, the sometimes perhaps excessive use of jargon and you know, words and the heavy words and I think, let me say the following. I think the words change, but the problems have remained the same. I think if we look back at the 70s, the time of Alma-Ata, well, it was also about trying to promote people's access to quality care and people being an actor in that, being not a passive recipient, having a word to say in these things. And universal health coverage is not very different from that. The language has changed because the world has changed. And universal health coverage is perhaps perhaps the words and the language that is, well, that is proper to 2012. But basically it's about the same thing. So in a way, history seems to repeat itself and the same things come back. What I want to argue for is that we need, of course, on the one hand, a language to communicate. Otherwise, we couldn't organize a meeting if we're using different words and talking about different things. But I want to plead also to try and give universal health coverage a face. A face. I think it is worthwhile at a smaller scale, be it taluk level or ideally district level, to try to develop locally a health system where people indeed, where universal health coverage is somehow implemented. By doing so, we will not, of course, change the problems in your huge country, but it will illustrate for external visitors, people who come and have a look at this, it will illustrate, it will show them that things are possible, that it is possible, that there's no need to be fatalistic, things can be done. And that it will also, I think, provide a source of inspiration on the how. How did you succeed in getting these? And this could then feed in the work they're going to do in their own settings. So I want to really to end with this. We need language, we need discussions between academics, policymakers, etc. But we also need, I think there's a desperate need for things that work at the local level, because it gives confidence. It gives confidence, and it's an illustration that things can be done. Yes, we can. It can be done. Good. Let me keep it here. I've taken a bit more time than expected. It's 5:05. I want to thank very warmly the panelists for their interesting presentations, the audience for their reactions, and I think there is some tea and coffee that is provided.
I just made the announcements.
Katja,
yeah.
Please.
Thank you. A warm thank you to all dignitaries on stage for a very interesting and insightful presentation and discussion. We would like to present our token of appreciation. A warm thanks to Professor Bart Criel for chairing the session and supporting us in this endeavor. Thank you, Dr. Sunil Nandraj, for raising vital questions on constant introductions of new global agendas, on the accurate of the kind of funding that is required for UHC. Thank you, Dr. Tanya Sheshadri, on sharing your lessons with us on the impact of RSBY in Gujarat. Thank you, Ms. Prakya Bhatt, on sharing your findings on differential financing for public health facilities. Thank you, Dr. Indranil Mukhopadhyay, on your presentation on health system strengthening and the importance of public investment through a study of NRHM in Bihar. Thank you, Ms. Sulakshana Nandi, for your insightful presentation on challenges in attaining UHC with your findings for RSBY in Chhattisgarh.